is the first panel in a 4-part implementation science series about adapting HIV and other interventions to distance models and addressing interruptions in the time of COVID-19. So the series is hosted by the Interventions and Implementation Science Core at the UCSF Center for AIDS Prevention Studies, Division of Prevention Science, and also co-sponsored by the UCSF CFAR Implementation Science Working Group and the Department of Epidemiology and Biostatistics Implementation Science Program. We all thank you for joining us. So we brought this panel together and the series of talks together because COVID-19 has really accelerated the ongoing work in delivery of digital health interventions. So today our faculty panel will discuss implementation science approaches, challenges, considerations around providing and improving implementation of mHealth and tech-based interventions to ensure that they work for everybody. So that includes addressing particular considerations for intervention delivery and research in under-resourced areas and under-resourced populations, research with elderly and language diverse populations, and also addressing disparities in education and support using our digital technologies in healthcare. The speakers will cover some of their current successes with digital health applications, adaptations of in-person service provision, use of social media and digital technologies for behavioral interventions, and also findings about how COVID-19 has changed or impacted our service delivery. This session is going to be recorded for later access, just so folks know. And you'll have each speaker have some time to talk and answer some questions at the end of their presentations, and then we'll have a time for discussion at the end as well. So again, thanks so much for joining us. Our first speaker is Courtney Lyles. Dr. Lyles is an associate professor in the UCSF Division of General Internal Medicine at Zuckerberg San Francisco General Hospital. Also a professor at the UCSF Center for Vulnerable Populations and the associate director of the UCSF Implementation Science Program in the Department of Epidemiology and Biostatistics. You keep yourself busy, it sounds. Dr. Lyles uses quantitative and qualitative methods in her health services research to examine quality of care, health behavior, and health outcomes. Her research specifically focuses on harnessing health information technology to improve patient-provider communication for chronic disease self-management to ultimately reduce disparities in health and healthcare outcomes for low-income and racial ethnic minority populations. So with that, I'm going to have Dr. Lyles take it away.
Great. Hopefully you can see my presentation. Just let me know if anything is weird. Thank you so much for having me and for that wonderful introduction. I thought I would talk today just a little bit about how I think about the state of digital health in the United States and how COVID has affected that, to get you on the same wavelength of how I think about these issues. And then I have 3 really brief things that we've been doing in the time of COVID that I thought might be of interest to you all. 2 are about telehealth, both telehealth data from the EHR and also trying to help diverse patients at San Francisco General use telehealth. And the 3rd is from a brief example of something we're doing to change our RCT to a remote RCT recruitment strategy that I'm guessing many other people are also thinking about in this time. So when I think about this issue, I just wanted to set the stage that I've been thinking a lot about the digital divide. And I think with COVID and the idea that not everybody has broadband at home, especially for education, I think this is becoming a little bit more commonplace kind of conversation in the last few months. But there are lagging groups of individuals who actually aren't on the internet or don't have a smartphone. This is data on internet use. It looks pretty similar by smartphone use in the United States. A majority of people now have access to all this information in their hands, but there are certain groups. This is showing income data. It also persists by education data, age, especially older adults, and rural versus urban differences on potentially some groups that are lagging behind. The second really interesting thing that affects sort of how we think about interventions is this new trend of smartphone dependence in the United States, a lot of which is built on the cost of home internet, broadband at home, so that low-income individuals, rather than lagging behind, like I showed you on the last slide, this shows the lowest income individuals in the United States being the most likely, over a quarter of them actually only use their smartphone to access the internet. So they do not have broadband or Wi-Fi at home, and so they are on a limited data plan. And this matters for things that I work on, like telehealth, because when you have a limited data plan for your month, you make a lot of decisions about whether or not you'd want to do like a video visit, for example, that takes up a lot of bandwidth versus other things that you're trying to do on your data plan month to month. So this is a really important thing for us to think about when we're intervening or offering digital solutions to participants and patients. There's not great data by language, but I just wanted to put up some older data. This also persists for non-English speakers and immigrant populations in the United States, and so specific needs among that group to get onto both internet and smartphone use persist as well, as in addition to the Pew data that I showed that was more about education and income. And then I'm having a little freeze there. There we go. And then the third pillar, right? So that's a lot about devices and a lot about broadband access. The third piece of it for my work is really about digital literacy skills. There's not great national data about digital literacy skills, but in San Francisco, we're very fortunate to have something called the San Francisco Digital Equity Initiative that's housed in the Mayor's Office of Housing and Community Development. And they did a survey a couple of years ago now trying to tease apart these issues. So this is all San Franciscans at the top and how they use internet at home. And then they broke out within those internet users, people who had both internet at home and who self-reported basic digital literacy skills. And they define that as being able to do an online search, finding websites, sending emails on your own. And you can see here that we are a tech-connected city, Silicon Valley, but for some of the same patient subgroups that we show differences in national data, they persist with having barriers here in San Francisco specifically. So non-English speakers, older adults, and low-income San Franciscans have some pretty steep barriers, both with internet at home and also with their literacy and being able to use those on an everyday basis. If you think about digital health tools specifically, so not just the broadband or the skills, but say, what are the types of things people are doing? There's survey data from places like Rock Health. This is just one example. This is a digital health incubator that you guys might have heard of, and sort of breaking out down the rows here, different types of digital solutions like telemedicine pre-COVID, wearables, things like that. And on the columns, they broke out from their survey respondents specific groups, and the ones that I'm most interested in and sort of the work that I do are chronically ill seniors and vulnerable individuals who they define as Medicaid or low income individuals. And you can see that those two columns have the lowest uptake of digital strategies and digital tools nationwide, except for that fourth row, searching for health information online, which looks pretty consistent across all of the groups that are surveyed. And the reason I like to show this slide is really, I think when we think about barriers to use, I really think the more I've done this work over the last decade, interest is not really the barrier. Almost all groups really have an interest in being able to do digital tools and digital health tools online. There are other fundamental barriers like the broadband and device ownership and the usability of the tools that tend to be some of the things that get people tripped up in being able to use them on an everyday basis. Okay, well, the whirlwind background, but just to sort of get you oriented to sort of how I think about the topic. And then I thought I would share just 3 quick examples of things that we've been doing the last few months. The first is that right after the pandemic, several colleagues of mine, Sarah Norrie, Elaine Kung, and Leah Carliner here at UCSF, looked at UCSF health data about who is accessing telemedicine. And we broke out, this is the same kind of groups that I showed you on the Pew data, trying to think about in the first few weeks after the pandemic, when we did a rapid switch in care to telemedicine for all patients, the same groups, older adults, non-English speakers, publicly insured individuals, and some racial ethnic minority groups were less likely to use telemedicine, even though they were using visits, they were accessing care and visits at a higher rate pre-pandemic. And so this brings up the same kinds of concerns. So not just from a research perspective, but from a practice perspective, how are we thinking about different groups and actually designing intervention strategies that actually specifically target these groups to make sure they're not left behind? So of course, we've been trying to do that. So that's like just the basic data from the EHR. In terms of how we've been thinking about doing that, we've done a number of things at San Francisco General to think about our telehealth rollout to make sure it's more inclusive of certain populations. We did a small study that's about to come out, I think this week or next week in JAMIA, that's just looking at, can we call up 300 of patients who are about to have a visit specifically either an in-person visit or a video visit, a phone visit, any kind of telehealth visit, and ask them about their interest in telemedicine, specifically their interest in video visit rather than phone visit for their care, and also what kind of barriers, document what kind of barriers they had to be able to access a video visit in real time. The bottom lines from this study are that, again, the interest is high. 65% of the patients that we called through were interested in trying video for their upcoming appointment. And 54% of them were able to download Zoom with us verbally over the phone and test out a Zoom download before their visit happened. So get the app on their phone, get ready for the visit, and try it out briefly with the medical student who was helping us call through patients. And in these 3 breakout graphs, you can see here there were some age differences in who was interested and who was able to complete, with the younger groups being a little bit more interested and able to complete, but that actually higher interest among the Latinx and the Spanish-speaking patients that we called through compared to other groups in our population. So again, high interest among many subgroups in being able to do video visits. The last thing I'll say about this study is we wrote down all of the barriers that they had and exactly what happened when we called them through and tried to walk through this. And again, of the half that had barriers to the video visits, data and internet access were the most common issues. So underscoring those fundamental barriers that I mentioned at the very beginning of the call. And then the third thing I thought I would show, because I definitely want to leave time for questions, is we have a randomized trial also occurring during the time of COVID. It's been very interesting to try to figure out adaptations to a randomized trial to make it ready for remote recruitment. This is specifically a digital health randomized trial called the DIAMANTE study. It's a text messaging based study that helps patients with depression and diabetes increase their physical activity. And so it has an app running in the background to help track their steps from their pedometer on their phone. And pre-COVID, we were doing that in person, right? We were meeting patients and downloading the app on their phone, answering questions for them, getting them all set up so that they could participate in the intervention. Post-COVID, we've been doing completely remote onboarding of our patient population into the study. And so we've triaged patients based on their baseline digital literacy skills to make sure that those who don't use apps very much, which is a pretty sizable portion of the patients that are being enrolled into this study, get an extra technical assistance, especially on the onboarding call, to help them download Zoom so that we can walk through the app download visually with them to be able to look at their phone and troubleshoot any questions they have. And they also get a lot of text message links. So they get the text message to do electronic consent form on Qualtrics. They get a text message to look at the survey that we're going to go through with them, and they get a text message to the link to download Zoom directly. So we get them on the phone, we start texting them the links to how to do various strategies, and then we're able to troubleshoot as we go through each step one by one. So this took work. I won't act like it won't take work to do this, but I think what I've learned from this is if you put some effort into it, you can add some time and really target the kind of help you need to get patients onboarded onto a study and make them feel like you've really walk them through rather than dump all of the steps on them at once, which can be really overwhelming regardless of who you're onboarding into your trial. So it's just like a smattering of things that we've been working on. I'd love to hear from you all. Moving forward, I would say just across these examples that I'm giving is I really feel confident that now is a really unique time to think about engaging participants and patients and using digital modalities more so than obviously pre-pandemic. But we really need to be consistent about how we communicate about how digital supports their in-person relationships and supports their ongoing care in ways. And I think that is a real key learning that can be woven through any research study or any practice modality in which we're using digital in a more enhanced way. And then moving up through the levels, I think systems and studies specifically really should probably know where patients are in terms of their device access, their internet access, and their digital literacy skills to be able to do that additional support that I mentioned, and make sure that the technical support is wraparound for patients to know and participants to make sure that they know that they can ask questions and get support and learning new skills over time. And then on a community policy level, I can't help myself by saying that there are so many organizations. I mentioned the Digital Equity Initiative, but there are public libraries, nonprofit organizations who actually have a lot of resources out there for individuals who are not digital natives, who want to learn how to do specific skills online. And I think we can do a lot better job connecting to those resources for participants to build up their literacy skills and their interest in doing various tasks, and also hopefully advocate for things like broadband as a more fundamental service, so that we in healthcare can have a similar voice of having access to this as a fundamental service for participants and patients, the same way that people in education have been doing over the last few months. So those are my soapbox. I'll leave you with one slide of some resources, in case you're interested in checking out a few more things. We have a toolkit that we just released that has some of the same kinds of content. It's specific to telemedicine, but a lot of these basic digital literacy links and tools exist within the toolkit. And also a great group called the National Digital Inclusion Alliance that keeps an updated list of low-cost broadband and device resources nationally, and also updated resources for COVID-19, special programs for COVID-19 for low-cost programs. So that's all I had. Would love to hear from you all.
Thanks so much, Courtney. That was great. We are running a little bit behind schedule, but I want to just open it up for a question if anyone has a burning question, and you can put it either in the chat or I guess raise your hand. I just don't know if I'm going to be able to see everybody since there's 3 screens worth of people. And I don't see anything coming in just yet, but Courtney, I was wondering if you've collected any data on changes in access over the past 8 months, like when you started, if there was a certain level of literacy and you're seeing an increase in the participants in your studies?
Great question. I'm not sure the basic access has changed that much, even though these lots of programs are available for a low-cost service. I'm not sure that has changed. Most people have had a device, and so they're hesitant, I would say, to sign up for broadband if it's not going to be in perpetuity a low-cost or free program for them, at least for the patients that I work with. But they are a lot more familiar with things like Zoom, especially if they have children or have used it for other things. They've had to learn specific apps like Zoom over and over again. So I have seen a lot more comfort with certain things over time in the last few months.
Right. Okay. So just in the interest of time, I think we'll move to our next speaker, and we'll have some more time to talk to Courtney at the end. Our next speaker is Dr. Parya Saberi. She's an associate professor at CAPS, the Division of Prevention Science, where she currently holds multiple NIH awards, including an R01 and R34 and R21, as well as funding from the California HIV Research Program. And her research includes assessing technology-based strategies such as mobile applications, video conferencing tools, and text messaging to improve adherence to antiretroviral medications and engagement in HIV care among youth living with HIV. She's also examining novel adherence assessment methods and an HIV pre-exposure prophylaxis tool for healthcare providers who are prescribing PrEP. She's also currently an expert consultant at the National Clinicians Consultation Center's HIV Warm Line, PEP Line, and PrEP Line. And we're excited to have you here, Parya. Take it away.
Thank you so much. Can you all hear me okay? Yep, okay, great. So thank you so much, Sherry, for the introduction, and thank you so much also to Rochelle and everyone who organized this presentation. I'm really excited to be presenting with Courtney and Ida and Judy, so I'm a little nervous both for today elections and for presenting with some of my favorite people. So I am going to talk about a project that I have been working on, and I feel like my slides are stuck now. Here we go. On pre-exposure prophylaxis for HIV. And I'm not going to go into detail on what pre-exposure prophylaxis is. I'm sure everybody here is well aware of that. So just to quickly dive in is that pre-exposure prophylaxis is really only straightforward if a lot of different conditions are met, including the provider being knowledgeable about PrEP, asking about sex and drug use in a non-judgmental way, figuring out insurance coverage issues, doing all the safety labs, and also that a lot of conditions have to be met about the patient. So kidney function being okay, not having any history of osteopenia or osteoporosis, hepatitis B surface antigen being negative, and being relatively adherent. So this is a result, these are some maps from AIDSview, and if you get a chance, I highly recommend looking at them. They have a PrEP to need ratio, which basically is a surrogate of how much additional resources need to be spent to increase PrEP use. And as you can see, there's been some progress between 2017, 2018, but still a lot of white space in the map of the US, meaning that we need more work and coverage. And some data from the CDC is that about 1.2 million individuals had a PrEP indication in 2018. And while PrEP coverage has gone up from 9% to about 18% from 2016 to 2018, there's still a lot of disparities, particularly in those younger age, racial ethnic groups, and geographic disparities. And one of the barriers that has been looked at, and I think it was one of the first barriers that I thought would be the most important to look at, is a lack of provider knowledge and willingness to prescribe PrEP. And as a priority step, the need to increase knowledge among providers and increase interventions to facilitate PrEP delivery has been indicated as an important priority step. So that's where the study PrEP-OI, or PrEP optimization intervention, came in, was basically to increase PrEP uptake and persistence by targeting providers. And the intervention included a PrEP coordinator, and I'll go into details on what they do, but essentially they're a liaison between the provider and the patient to try to increase PrEP uptake and persistence. And we also developed a tool called PrEP-RX, which is a web-based panel management tool that basically was there to help PrEP coordinators and providers to increase the efficiency and the efficiency of PrEP starts, and also adhering to a lot of the CDC guidelines, which are just very tedious at times. So the primary aim of the study was to increase PrEP prescriptions using a stepped wedge design among 10 primary care clinical sites. So it was actually 12 clinics, but 3 of the clinics were combined because they all had similar staff and similar patient population. So we call them 10 clinic sites. And the idea was that the intervention would span the entire PrEP cascade. So really quickly, the PrEP coordinator's job was essentially to do everything that any medical provider would do, short of signing off on the prescription and answering any clinical questions. So essentially, they would do all the appointment scheduling, the monitoring, the STI self-swabbing, teaching, assessing for HIV risk, even writing the prescription so that the provider could sign off on it, and then doing everything thereafter, all the weekly, monthly, quarterly visits, and all the lab appointments. And the PrEP-RX tool that we had created, and this was using a Salesforce backend, was to essentially increase efficiency of the workflow of the PrEP coordinator. And it includes a survey to assess risk. So the questions are very clear and it's pretty comprehensive. It has these automated reminders, so the PrEP coordinator just gets notifications whenever the patient's due for anything. And it has a PrEP timeline, so you can see very easily where a patient is within their PrEP use or in prior PrEP timelines. So as I said before, there were 12 clinics, 3 of them bunched together for 10 clinical sites, and they were randomized in this stepped wedge design. Essentially the study went until September of 2019, and then we had a 1-year follow-up phase until September 30th, 2020. And of course, that's when the pandemic occurred during that time. So the data that I'm gonna present are from the time of the pandemic and how we modified the study to make it fit. In the meantime, I also had done another study, which was a online survey of individuals who are on 2-in-1 PrEP. And essentially some barriers were identified that I thought were interesting, including patients saying that they encountered difficulties with getting their lab tests, refills, appointments with their providers, communication with their providers. And for a lot of individuals, they had either completely stopped having sex, or exclusively meeting with prior known partners, or just having less frequent sex. So we really wanted to address some of these problems that we were hearing both on the survey and also verbally from the patients from the clinics. So there was 4 responses that we had. And I've basically been working on having remote research or promoting remote research since I want to say 2011, and really the pandemic, unfortunately, was really fit within that model. So PrepOI was already set for a remote delivery of services because we were already doing telehealth and text messaging. So we just really increased that by allowing the prep coordinators to work from home so that it would also reduce the patient visits to the clinics and allow for continuous support. And this was actually really important for a lot of the patients because they were given a contact person through text messaging that had a relationship with their clinic. So they can very easily text message their prep coordinators, even for things that weren't even related to prep, to be able to get the attention of their medical provider. So this also helped with refilling medications, discussions around STI symptoms, and also people experiencing side effects from PrEP. On top of that, it allowed for the PrEP coordinators to discuss options instead of having someone discontinue PrEP altogether, what may be some other options, and I'll go into that in a second as well. So our response number 2 was to come up with our own guidance because essentially the CDC guidelines require quarterly labs, and that was really just too much for the clinics and the patients. A lot of clinics had reduced hours, their labs, some of them were closed, and also a lot of patients just didn't want to come to the clinics because of fear of exposure. So we basically revised our own guidelines. So essentially we did 2 things. One is that we defined what was an essential in-person visit. So that included when patients were starting PrEP for the first time, so for their initiation labs. So that was really important to get people into clinic. The second was for any follow-up lab, if patients hadn't done labs in the past 6 months. On top of that, if anyone was experiencing any side effects or STI symptoms, which sometimes also resemble some of the acute HIV or COVID-19 symptoms. On top of that, we determined when patients can come in. So we basically had this guidance that if someone was already adherent to PrEP, they'd been coming in for labs, they didn't report any signs and symptoms of any HIV or STIs, instead of doing quarterly labs, we would do labs every 6 months, and then we would refill their meds for an additional 3 months. If someone was having any problems with adherence, but they weren't reporting any acute symptoms of HIV, we would refill their meds for an additional month after their 3-month test, and then have them come in, instead of coming in quarterly, they'd be coming in every 4 months. And then if anyone reported any acute symptoms, we would coordinate for them to speak with their provider. And of course, the CDC eventually did come out with guidelines, but it wasn't until May 15th, so about 2 months later. And actually, the guidance was quite similar to what we had already said. So it was great that we were able to take action so quickly. Our response number 3 was to provide options. So instead of having people either be on PrEP or not be on PrEP, for all the MSM and transgender women in our population, which is the vast majority, we even-handedly discussed 2-1-1 PrEP. So this is when you take a double dose 2 to 24 hours before sex, a single dose 24 hours after the double dose, and then a single dose 24 hours after that. And we told patients that this is an option, that instead of discontinuing, they could consider this, so we are not losing all of the HIV prevention models and successes that we had gained. And then the 4th thing was that through an administrative supplement, we were able to work with a remote lab so that patients could eventually do labs remotely as well. So again, this was because of the lab closures and patients being reluctant to go in. So we basically worked with a group called Molecular Testing Lab and I applied for this COVID-19 administrative supplement to look at feasibility and acceptability of doing HIV prep labs as well as SARS-CoV-2 labs remotely. So this just really quickly is for 100 patients who are on PrEP and covered by our study, and the test would be a 5 drops of blood for a dry blood spot, where they do 4th generation HIV testing, which is really important. Serum creatinine, Hep B, Hep C, syphilis. We're doing SARS-CoV-2 antibodies and pregnancy tests as needed. There's a 3-site STI swabbing, as well as a self-collected nasal swabbing. And there's an Oscar-winning video on this website, prep.ucsf.edu, which is our website, with my darling husband as my model, demonstrating each of these labs, not including the rectal swab though. But you'll see, it's really cute. So these are data we haven't yet published, but we will soon. And essentially, I think what's really important is to show that from January, before the pandemic, until September, and I just got the data from October and didn't have a chance to update the slide. Essentially, we saw no change in PrEP use. So, while a lot of other clinics, like, there are data from Boston, from our own Kaiser here in Northern California, as well as other countries like Australia, where they've shown a huge dip in their PrEP use over time. We basically didn't really see much difference since the beginning of the pandemic. Now, we didn't have the growth that we were having before the pandemic, but at least we were able to sustain people. So in blue, you have the people who are actively on PrEP. So they've told the PrEP coordinator that they're putting a PrEP dose in their mouth. So essentially, there's really no change. So just a quick acknowledgement of all the individuals who helped and were co-investigators on the study in the National Institute of Nursing Research. And this is our website, and it has a ton of tools in different languages as well, if you want to check it out. So I will stop there.
Thanks, Parya. That's amazing. So it's amazing that you were able to maintain PrEP use at the pre-COVID levels during COVID. So congratulations to you and your team.
Thank you.
I think we're going to go to the next speaker just because we don't have a lot of time. There's so much interesting things to get to, but I want to encourage folks to put questions for Parya in the chat, and she can respond privately or to the full group. So thanks so much. Our next speaker is Dr. Judy Tan. Judy is an assistant professor of medicine at CAPS, Division of Prevention Science. She's a behavioral and prevention scientist trained in social and health psychology, and uses quantitative research methods as well as intervention development to elucidate multi-level causal processes of health and to develop novel interventions to reduce health disparities, particularly those among gender and sexual minority people of color. So Dr. Tan is the PI of an R01 funded by NIMH to develop mHealth capacities that target and leverage dyadic factors for enhancing HIV care engagement among Black, gay, and bisexual men. She's also the PI of a National Institute of Aging R21 to develop a choir intervention to promote psychosocial well-being among older people living with HIV. And her research interests include food insecurity, HIV and aging, smoking cessation, and dietary acculturation and cancer risk. So, Judy, thanks for joining us today.
Thanks so much, Sherry, and thank you, Rochelle. And I want to parrot what Parya just said. It's an honor to be on the same panel with Ida, Courtney, and Parya. Ida was obviously a seminal figure in my training in my KO ward leading into the R01 that I will be talking about today. So I want to quickly go, so I want to talk primarily about the 2 studies that Sherry just mentioned, but specifically about how we've had to adapt our recruitment strategies and what we've seen as a result of this adaptation And then with the choir intervention, how we've had to start thinking about our research question differently. So the R1 that Sherry mentioned is a mobile app called LetSync to promote HIV care engagement among Black men and couples. So we were funded in 2019, and we are currently recruiting. We're in AIM-1. Basically, the timeline is doing interviews that were pre-epidemic, pre-pandemic, was supposed to be in person. So AIM-1 interview was supposed to be, so basically, just to give you an idea, so the trial is supposed to be a pilot test of the app with 80 couples, but with some of the visits being remote and some of the visits being in person. So currently we are still in phase 1, or we're doing AIM-1 research, in which we're trying to really understand, conducting via interviews, really trying to understand how resiliency among African-American men in couples, kind of a stigmatized relationship in society, especially in current times, I think, how that may be leveraged in care engagement. So the inclusion criteria for 24 couples, a total of 48 individuals, is that at least one person in each couple is a Black cisgender man living with HIV. And the proposed recruitment approach it's very similar to how we typically do things, right? In-person outreach, print and online advertisements, and using different resources that we have available, including CTSI, mailing letters to patients found eligible in our EMR, as well as our community engagement efforts that Barbara and John run. So the recruitment for LetSync began late February 2020, and then of course we had to switch gears and really start to think about how we might want to engage folks, especially given that this is, as Courtney has mentioned earlier, that there is this literacy, this access to literacy issue. From my own, qualitative research, I found that the interest is always there. And then in the Bay Area, there are, the access is slightly better, if not a lot better than most of the folks around the country, in terms of looking at just African-American communities. But because of the pandemic, we really wanted to start to open up the eligibility criteria, because whereas before we wanted to bring folks in to do in-person interviews, we started to consider really expanding our geographic engagement to areas outside of the Bay Area. So if we look at I charged my team to start to identify various community-based organizations, or CBOs, clinics, aid service organizations, various organizations around the country, leveraging email listservs and Facebook, and anything that we can find online to start spreading the word about this one-time interview that we were doing on Zoom. And then one of the things that we did not put a lot of stock in to thinking about was leveraging dating apps, gay dating sites to engage the sample. But we decided that because we were quite desperate, it was it was very apparent and earlier on that it was very difficult to recruit couples, and not just individuals, but couples. So even if one person is eligible for the study, if one of the partners, you know, refuses or is ineligible, otherwise ineligible, you know, we're dead in the water. I mean, that, you know, so we really, you know, becomes really difficult, as people in the audience can realize, who do dyadic research can appreciate. It's very difficult to get couples into the research. So we decided to really expand all possibilities, and then and to engage folks on dating apps. And lo and behold, what we did find, the strategy that we found the most fruitful actually was so far is via dating apps. So we've had success in through painstaking engagement strategies, and we're currently working on publishing that paper, writing up the results of that paper so that we can describe the you know, the novel ways in which we're engaging folks on dating apps to recruit couples. So we've been able to also leverage other methods that are pretty typical in our research. And as of yesterday, we were able to include in our sample for AIM-1 21 couples, a total N of 42, which I think is just a tremendous, tremendous testament to the hard work of my team. So to give you an idea of where participants are located, we have, of course, folks here in the Bay Area, but we were, as a result of expanding our geographic criteria, we're able to include folks from other regions, including couples who do not live together and actually live across the country from each other. Now I want to switch gears to talk a little bit about something that I am less sure about, and I'm still currently grappling with, which is my choir intervention, a group singing intervention for older people living with HIV, the United Voices Project. We all can appreciate that there's still quite a lot of stigma, especially experienced by older folks living with HIV. And as a social psychologist, I know about this large body of literature supporting the premise that fostering group identity and pride in a group comprises a social cure for psychosocial impacts of stigma. These impacts may include loneliness and social isolation. And for older folks, experiencing pride in part of a group of similar others and feeling personal control or gaining personal control may buffer against these impacts. So one of the objective of this research, the R21, is to leverage singing and singing in a group as a intervention strategy, which was quite novel. At the time, so we were funded earlier this year in January, and then of course pandemic hit. We obviously could not bring folks together. So one of the things that we're now trying to grapple with is, okay, so if we can't bring folks to sing together, what can we do, and what are the mechanisms of action that alternative methods can still actualize? So the proposed mechanisms of action include engaging in regular social activity. So this is kind of the schema that I proposed, illustrating how singing in a group, how United Voices as an intervention can buffer against the impact of HIV stigma to mitigate its effects on psychosocial well-being. But I just want to very, very, very quickly show you that one of the ideas that we're currently contemplating is doing a virtual choir. And there are many, 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 including folks on our staff who are in choirs, many examples of virtual choirs, such as this one. So in the interest of time, I won't continue, but I just wanted to give you a sense of the creativity from the community in response to the pandemic, that folks still want to sing and still want to gather. And currently what I'm talking to my project officer about is how are the proposed mechanisms of action going to still be enacted, to be activated in a virtual choir setting. So these are uncharted waters. Obviously, everything that we do will be, unprecedented. I guess one of my messages today is to really reiterate that, I'm really struggling to figure things out. And if anything, I just want to leave folks with the idea that that there's a first time for everything, and that creativity is key here. With that, I want to thank my team, Cindy, Robert, and Javon, and special thanks for DuoPact and referring participants to us. Thank you.
Thanks so much, Judy. What an interesting thing to be studying social isolation right now, and that started out as an HIV project. Really interesting timing. In the interest of moving forward with our last speaker, anyone who has questions for Judy should put them in the chat. And I'm really excited to introduce Dr. Ida Sim, who's a primary care physician, informatics researcher, and an entrepreneur who co-directs the Informatics and Research Innovation at UCSF's CTSI, Clinical and Translational Sciences Institute. She's developed novel technical and policy approaches to build digital infrastructure for data sharing as a public good, and has co-founded a number of organizations. I'm going to keep the introductions short to give Ida more time to speak. So go ahead.
Great, thank you everyone, and thank you for putting this on. This is an implementation of digital interventions in the new normal, abnormal. I actually lose track of what's normal or abnormal, so we will just leave that. But I think everybody realizes that in this time of social distancing and the pandemic, that virtual care is super important, and that remote monitoring in addition is also very important. Patient-generated data, which I define as being data from sensors, from other sensors that may be around your home, for example, not just the wearables, home medical devices like BP cuffs, and then patient-reported outcomes. It's patient-generated data that provide a remote window into patient health states, which is so important now as people are not coming to the clinic nearly as much. And with a lot of innovation, I've heard some of the innovations described already earlier in this hour. The question is, how do we get from here, which is 1,000 flowers blooming, which in my mind just leads to a lot of seasonal allergies. Where do we really want to go? Well, we actually don't want 1,000 flowers blooming. We actually want a small bouquet, right? We want the right flowers together for the right purpose, for the right person. And it's really challenging this arrow is really challenging. And I'll use an example just here at UCSF. Let's just take an example vignette of a patient at UCSF who has high blood pressure. And these are actually projects that are going on at UCSF right now. Population Health is working with patients like Miss P, giving her an iHealth wireless cuff. It connects through MyChart. There are all these pieces together, and they use the UC Davis Better Blood Pressure Program to funnel blood pressure data to a team management. Let's just say that Ms. P is also a strong supporter of clinical research, and maybe she's enrolled in the Optima for BP research study, which is ongoing in our clinic, which is from cardiology, and that uses artificial intelligence to advise doctors on the next best therapeutic step to either increase the dose, add a new drug, for example. And in this project, Ms. P gets an Omron wireless cuff, and she has an Optima for BP smartphone app. And of course, now with the pandemic, UCSF Health itself is asking patients to self-report their home blood pressure readings via MyChart. you can see where this is going, right? She's, this patient's going to get confused. Which apps, which sensors, which programs is she using with UCSF? Why is it that her data is going to her primary care doc, but not to her cardiologist? And, at some point, she can start to feel uneasy about her data relationship with UCSF. And here we're just talking about blood pressure. We're not also talking about blood glucose. We're not talking about, PROs. You can imagine this can really multiply to be a problem. And just graphically, just trying to show this in a table form, you've got different clinical units who are using different tools, different cuffs, different integrators, delivering the data to the doctor in a different way. We've got different clinics who are sort of going off on their own to do things. And then we've got research projects that are also, addressing each of these pieces. And overall, it just adds up to a lot of pain points. So taking it from the perspective of UCSF, and for those of you, I'm very happy to see people from outside of the country even, just think about it, as a healthcare organization, right? What are some issues about that? Well, with multiple projects, building and rebuilding the same patient-generated data infrastructure to ingest the data, store the data, send it around, it just multiplies the cost, quality oversight, and security risks. And this fragmentation really impedes governance over the projects that are being done by the multiple faculty, the multiple clinics, and then the health system itself. I think it's a real challenge for patient trust as well. As a patient, I may be using a number of different devices, not knowing where they're going, starts to erode potential trust. And then UCSF has a harder time managing that data relationship because we don't have a clear view of what sensor and what data is coming in and being used by different parts of the health system and on the research side as well. And of course, because we're a research university, we also do actually want to collect all this data, right? From the different blood pressure cuffs and the glucometers and the step, sensors. But we want it in the same format, and we want to have clear consent so that we can use that for, for other research later. And we also want the data to come in and then go back out to the clinician in a way that makes sense for us, at the pointy end of the workflow when we're actually taking care of patients. And if we do this sort of one-off digital implementation, we kind of lose control of how all the pieces might fit together. And it's fine when we're early on, in digital health innovation, but I think we're getting to the point where we really need to think about how these things are going to come together, because these pain points are just going to get more painful over time. Now, I have a separate approach which uses open source tools and open source, approaches, but a very common approach that's being taken, and actually is being taken by our health system at UCSF now, is to use EPIC, which is the EHR that we're on, in the MyChart patient portal. So here you can see that you can order a blood pressure collection from a patient, okay? You can say how often they should collect their blood pressure, what are their thresholds that you want to be notified for, so you can customize the thresholds for your particular patient, which is super cool. You can see this is just like an order screen, and so you just accept, and off you go, you've made the order. You can also manage the workflow. How often do you want to get a report? What are instructions to the patients? If they're abnormal, if the threshold is exceeded, you want that message to go to you, or maybe to go to your nursing pool, right? So there's support for notification workflows. And of course, there's one for blood glucose, but a similar one for blood pressure. And then once you put in the order, just like you would order, any lab test, the patient then needs to go do something. And here, the patient would actually connect their wireless blood pressure cuff through, it says Fitbit and Withings here, but that's not right for this example. They would connect through Apple Health Kit or Google Fit, okay? And then the data would come in and would go directly into Epic. And then they also get to see their data on MyChart, and then the clinician sees it on something called Synopsis, which is another part of Epic. And here you can graph both the clinic collected blood pressures and the patient generated blood pressures on the same graph, okay? This is just starting at UCSF, and great excitement, because it's going to end up like this, where the clinical units are, really going to work with the medical center and use this approach of Epic MyChart. These are the cuffs that can be integrated from Google Fit and Health Fit, and then all the data shows up in Synopsis and Epic. So much cleaner than the previous one. And you would say, well, how about that? Is that good? Here I would say, let's back up and say, who are we taking care of, right? In primary care, I'm at the DGIM, General Internal Medicine. We have 25,000 patients. Here I've got my quick poll that's just popped up on my screen here. So just get rid of that. Okay, are people seeing my quick poll? All right.
No, we're not seeing the poll, Ida, sorry.
Okay, it's popped up right in the middle of my screen here. You know, there's a lot of diversity in our patients, as you can see here. Lots of people speak different languages. Courtney has gone over some of the issues of, you know, access both to internet technologies and also digital literacy, which obviously comes up. I'm not going to talk about those issues. I'm going to talk about what it means here for you know, using just the EPIC and MyChart approach. So as a pro, there are many pros to this, right? MedCenter has full control. All the clinical units are using the same approach. You know, the clinicians get the data in synopsis. Remote data is stored in the EHR and it's good for billing, which is absolutely important. And it's device agnostic, right? We're using Apple Health and we're using Google Fit. And very importantly for patients, MyChart is a trusted one-stop shop for a lot of EHR activities. There are some cons though that I want us to be thinking about. MyChart is not user-friendly and usage is not 100%, though it's now 80-something%, you know, with the pandemic. Tremendous amount of user training and support is needed. But there are equity issues, I think, about using just MyChart. MyChart does not support character-based languages like Chinese. And this approach, you know, health kit data stays on the iPhone, but with Android users, to use Google Fit, the data is being shared with Google. You know, that's just the way it works. And so we need to be thinking about, are we exposing our patients to sort of additional privacy threats? And for a medical center like us, which is, you know, an academic one, I struggle with how digital health research fits in. Because if we stay with the EPIC MyChart approach, we have to use EPIC's decision support tools, which are kind of clunky. We're restricted to using EPIC's user interface, which is kind of clunky. We're restricted using commercial devices that integrate only with HealthKit and Google Fit. That's a restricted set of devices, of course. What if we're partnering with, you know, colleagues at Berkeley who have a new sensor? What if we, you know, there are many, many reasons why we don't want to be restricted. And then MyChart doesn't support patient-facing decision support. So that really limits the kind of research that we can do to bring digital innovation in. That's been a problem before. You know, we really want to have more extensibility and flexibility so that we can get to these individualized bouquet. And I would now add to this that we don't want just that one bouquet, right? We have many different bouquets that we need for different users. Some people are more technically literate, some people have Android, some people, you know, need many, many sensors because they have a lot of chronic conditions, some don't, and it's gonna change over time. How do we be flexible so we meet patients where they are and still manage the flow of innovation and security that we need in our implementation? COVID has made everything a lot more challenging right now because there is so much pressure on the clinical IT side to deliver innovations. All innovations touching our UCSF EHR now require executive level approval from digital recovery solutions, which just makes the bar even higher for doing digital health research. So I'm concerned about how that's going to add up, right? So in summary here, I think just to be thinking that to be successful, you know, there are individual innovations that we need to study, as you've heard already. We also need to be thinking about how these innovations come together to be useful and usable by individuals, right, as individualized bouquets for each person that might change over time. We need to think about how it's sustainable for systems, health systems, large ones, and particularly for academic medical centers, how we balance the tension between digital innovation and the need to, you know, have control over our technology and our security and our patients' experience. And all these pressures, I think, are only going to get higher as, you know, in the face of severe financial and staffing constraints with COVID-19. But I think it's really pushed us to think about governance and about how we implement technologies that need to be tested, but in the end, we do want them integrated into the healthcare system and what that looks like both for our patients and for us. And I'll stop there.
Wow, it's a tour de force, Ida. I'm wondering, I don't see any questions posted. I know we're at the hour, but I'm hoping people can stick around for a second, and so can you. I'm just wondering about, you know, like there's an antitrust suit right now with Google, and I'm wondering, you know, your comments about how Epic and the medical center only work with certain, you know, companies and their digital projects, and I'm just sort of curious if there's a movement to change that.
Oh boy, that's a tough one because, you know, these are private actors, right? So Epic is working with Amazon Web Services. They also have a partnership with Microsoft. UCSF has established relationships with Amazon and with Microsoft. Google's somewhat left out of the party right now. That may change in the future. But I think there are decisions that need to be made at the institutional level that then impact us. And they end up, you know, there was this whole breach, right, of data, and UCSF had to pay a ransom. So that's the context in which digital technologies need to be managed. And so, you know, those of us who are doing research, if we want our work to have impact, need to be thinking about how we fit into that bigger picture, and then incumbent upon us at you know, the leadership positions at an academic medical center to make the case that there needs to be room for the kind of digital innovation that we do.
Yeah. Well, I'm not sure if there are any other questions from the audience. No. I mean, I don't know if any, go ahead.
Sure. Just one comment I just want to make, and it is a comment, it's not a question. But in listening to this, what's interesting to me is to think about the policy landscape. And it's just worth noting that there's a, you know, a lot of what enables the funding of the telehealth services right now in the COVID era is possible because emergency regulations were put in place at various levels, such as within the Medicare program or within certain state programs and things like that. And it's really not clear where those are going to land when we come out of COVID. I mean, not helped by the fact that we don't know what's going to look like as of tomorrow, the federal level, but you know, there's an awful lot as reflected here that people are doing to adapt. Some of it is clearly being done because we're kind of forced to be in it, and maybe we'll look a little different afterwards, but there's also a lot about things that really work well for patients and things like that that may actually be worth sustaining as we go forward. And it just remains a question mark as to what that landscape will look like for paying for some of those things when we move past COVID.
Yeah, it's interesting to think about how the landscape will change completely in terms of the production of digital health provision with COVID and with the end of COVID, and whether we'll see some sustained differences in how things are delivered. I don't know if any of the panelists have a final comment. I did want to say that this is the first in a 4-part series, and that we will be having discussions in the coming weeks around different methodological approaches to address changes and interruptions in research due to COVID, ethical issues that come up around changing our study designs and our delivery of healthcare due to COVID, and also discussion of study design and how to deal with things like COVID when they come up. So I want to encourage people to attend those meetings as well. If anyone has a final comment, I'm happy to open the floor. And if not, I will just, you know, send a shout out to the 4 speakers. Amazing work that you're all doing. And hopefully we'll see you in the next session when we have hopefully good election news to share as well. Something to celebrate.
Thank you. Thank you for hosting.